Today, on this episode of The Brain Surgeon's Take, we will be discussing the psychology of cancer with clinical psychologist at the Sylvester Comprehensive Cancer Center, Dr. Wendy Lichtenthal. Understand the mental aspect of cancer and how patients and their families cope, not only with this life-changing diagnosis, but also tolerate treatments and eventually deal with bereavement and grief. Much more on this podcast episode. Welcome back, everyone. Here's my take on Wendy Lichtenthal. She's on the front line of the scariest diagnosis in medicine, cancer. Imagine yourself or your loved one being told they have cancer. It's a life-altering event for the entire family. We understand the physical aspect of cancer and how best to treat it. But what about the mental component behind this condition? From the initial shock to the potentially grueling therapies to the possible coping with death. The psychology of cancer is just as important as the pathophysiology. During this interview, Dr. Lichtenthal does an outstanding job explaining her role as a nationally known clinical psychologist and cancer expert. She takes us through the multiple psychological phases cancer patients go through and how her and her team help them stay in an optimal mindset. It's clear that cancer care needs to be holistic, and at the center of that needs to be mental health. I give Dr. Lichtenthal kudos for devoting her career to this topic and advancing cancer care across the country. Listen up as we discuss the psychology of cancer. Check it out. Hey, Wendy, how are you?
I'm great. Thank you so much for having me today.
No, listen, it's great to have you on the podcast to talk about what I feel is a very underappreciated part of cancer care, and that's the psychology behind cancer care. And that's what you specialize in. And I look forward to hearing your thoughts on this critical topic.
Absolutely. I'm so glad to share more.
Let's start with your journey into this topic. How did you first get interested in this field?
Sure. So for me, like for many people, something personal often drives the mission, the sense of mission. And I'd lost my dad when I was 13, going on 14, not to cancer specifically, but I think that loss experience at the time where my kind of identity was being formed really led me to want to understand how to help people when they're suffering, when they're carrying big emotions, when they're facing adversity. And so my focus had been really in the realm of grief and bereavement and medical situations, health issues. And then in graduate school, the path that I ended up kind of immersing myself in was oncology. And so a lot of what I was bringing in the grief and bereavement realm in terms of coping and how we think about it, how we make meaning, because certainly my path was making meaning of my own experience. So a lot around that meaning making and how do we cope came to be in the realm of oncology. And I've been in the field since then, since around 2000.
Now, it's such a shocking diagnosis, right? Probably the most scary diagnosis anyone can possibly receive. And for someone like myself, I give out that diagnosis commonly, but then we
Yeah.
move on with our day because we have other patients to take care of. But give us an idea of what that initial diagnosis of cancer is like. How do most patients typically respond mentally?
I think shock is really common. But I really also think that the reaction depends on the meaning they're making of the cancer diagnosis. So everybody comes to the experience of cancer with a different lens. Some people have a sense of identity that where they feel really healthy and cancer is not in their world. And so this is completely blindsiding them. And then for other people, I think, if they do have a family history, their kind of point of view might have been just waiting for this to happen, that this could happen any day. And they maybe lived with some anxiety about it. And now here it finally happened. So I think really the meaning of the diagnosis, what they know about cancer, who they know, what they've seen in the media, all of that shapes that reaction. But certainly a very common reaction is shock. And kind of now needing to integrate that. And then a lot of other emotions come with that. So because it often derails kind of immediate plans and maybe threatens longer term plans, there's a lot of kind of reorienting and regrouping and kind of taking it in that happens. So initially, though, it's kind of processing that. And then a lot of times people go into, with their medical team, go mode. Okay, what do I do? And so I think, and maybe we'll talk about this some more, what happens kind of then while they're in active treatment or kind of coping with it is very focused on the next step. Um,
Yeah, I mean, take us through, and you kind of alluded to it, like the stages, right? Not everyone's going to stay in the same psychological stage throughout all of cancer after
yeah.
hearing that diagnosis. What are the typical, if there is such a thing, psychological stages of patients that are diagnosed with cancer? And do most patients fall into that type of progression?
Yeah, I'm glad you asked about that because I think there is such a drive for all of us, for providers, clinicians, for patients, family members to want to think that there's some specific trajectory. And so that term of stages, I think, is used a lot to explain phenomena, a psychological phenomena, but it's actually a little dangerous to use that kind of terminology because then people expect a certain way to react, and really it's so individual. It's really so individual because someone, again, there are common reactions, and so our job is often to normalize whatever we're seeing and explain that however someone is reacting makes sense based on what they recently learned, where they're coming from. But after that kind of processing, like I said, a lot of times people who are given a treatment plan move into that treatment plan and they're kind of in go mode, kind of doing a little bit on automatic. Certainly along the way, there are a lot of emotional reactions that might come in waves, waves of anxiety, waves of lower mood, coping with the physical toll, and grief over, again, plans that were derailed, kind of fear that something that they imagine for the future isn't going to happen. So that grief, that fear, lower mood, um, frustration, anger, why is this happening, and trying to make sense of this is something that is so common. But when we think about a stage and a prescription or something that can feel prescribed, the danger with that is that someone's going to say, well, what's wrong with me that I'm not kind of sequentially moving through some trajectory, when that's not how we actually work. We get new information from the medical team, from a friend who had a friend who had the same diagnosis, and waves of emotion come over us, and then we kind of regroup and again continue that making sense of this. And how do I understand how this happened? That's our drive as human beings. We want the world to be predictable and understandable, and sometimes that turns outward. We think about how did this happen to me because of external forces, and sometimes that turns inward in terms of one's own behaviors, that as people try to explain, how did this diagnosis happen. So a lot of that also in the earlier phases is happening for someone.
Now, I think you said it best, right? Going through the treatment, it's important to realize cancer is a marathon. It's not a sprint.
Hmm.
Many cancers, long treatments, grueling, exhausting. What is the most common mentality? You mentioned the go mentality. Take us through what most patients, how they mentally get through that grueling, long, arduous treatment.
Well, I think in that go mode that I'm referring to, I think there are some people who are kind of high in need for information. So there are people who are doing a lot of research. They're scouring the internet. They're trying to figure out, because again, there's this drive for predictability to understand what's going to happen because we don't like to sit with uncertainty. So there certainly are patients who are in that mode where they're trying to understand what is happening here while following the directive and going through treatment plans, maybe getting other opinions. And then there are other individuals who just want to be told, like, tell me where to be, what to do. They kind of want to just get through it. What's interesting is that in terms of the support that clinicians like myself who can offer, we I don't often see people, or I more typically see people when there's a pause in treatment, because it's when you're not in that go mode that sudden you're like, wait, what just happened here? I have to kind of take this all in. And that's when sometimes, surprisingly, even it might be the conclusion of some active treatment phase, that people actually kind of get hit with what just happened here. Existential distress starts coming up, like, what have I been doing with my life? What does this mean for my life? And certainly anxiety, kind of because of the threat that's now in their world. The curtain has been pulled back. Life is finite, these kinds of ideas that most people are walking around not thinking about on a daily basis. Suddenly that curtain is pulled back, and all of these thoughts about the scariest of things are now in their worldview.
So like you said, life is finite for all of us.
Yeah.
Take us through how, so we've gone through the initial diagnosis, we've gone through the treatment, which can take a long time and be really protracted. Tell us about end of life and palliative care. How do patients typically cope with the finality of their time?
I guess, again, this idea of typical, I'm gonna push back each time because it's
Mhm.
so variable. And one thing that I often say in working with patients is whatever they're experiencing makes sense. Right. So if we look at their life history, we look at their circumstances, we look at the trajectory of treatment, or maybe aspects of their treatment that they think they wish they had taken a left instead of a right. There are all these kinds of things that might come up as people face a poor prognosis. How did I get here? But existential distress, that idea about kind of how, looking at one's life, a life review, and wondering if they've lived life in a way that aligns with their values, concerns about unfinished business, and grief over that, and grief over the prospect of being separated from the people they care about. All of this can really come to the fore. A concern about the people in one's life and wanting to take care of matters so that they feel don't feel burdened by that might come up for some people. And then for other people it might be a wish, a continued hope for something to change, right? People may lean into their faith, they may lean into continued searching for a cure or way to prolong life. They're all different reactions. And so that kind of, I want to feel like I did everything I could, might be more typical when someone feels like there are people counting on them. So, those who have younger children might want to think, I've done everything I possibly can. And so moving into a coming to peace with that prognosis might be much harder. Whereas someone else who really looks back in their life and feels like it's a life well lived, that and has kind of a framework where this fits, where this diagnosis is happening in their life and what they've done, they feel at peace with that. That might be someone else's reaction. So there's a lot of variability. But what we do when we're supporting individuals is, again, help them make sense of their reaction, normalize and validate all the distress that might come up, the grief, the anger, the anxiety, the lower mood, the existential distress. We're going to be mindful that all of that could come to the fore, and help support individuals through the all those different kinds of reactions.
Now you mentioned how anxious patients who have cancer can be. Something that I feel is very underappreciated is the anxiety when you're in remission, right? Everyone talks about, "Oh my god,
Yeah.
you're in remission, that's great," which it is great, but the anxiety of every PET scan, every MRI, just waiting for what people might think is just inevitable. And I know that my patients
Yes.
get brain MRIs every 3 or 4 months when they have brain cancer, and they all tell me that when they get the MRI, like the 2 or 3 days until they hear back is just crushing in terms of anxiety.
Absolutely.
Talk about the power of anxiety in patients who are in remission, whether it's brain or breast or colon or lung, and they're getting screened on a semi-annual basis. What do you think about that?
Yeah, so we call that anxiety, right? It's a this specific surge of anxiety that comes around the times that you're being monitored, and it is, what's powerful about the fact that it's a surge is that in the in between, many individuals find a way to coexist with that background possibility, that threat. Of course, fear of recurrence is more common than not. So most individuals who've been affected by cancer and have concluded treatment have some anxiety. Some individuals, again, figure out a way to coexist with it. It's background noise. It comes up, it surges, and they kind of surf that wave of anxiety. For others, it is much more preoccupying, it is part of their daily experience. And what our goal is when we are supporting individuals is never to take away anxiety. When I meet someone, I say, my job as a therapist will never be to eliminate your anxiety, because anxiety has utility, right? It's telling us how to, in some ways, take care of ourselves and do things that are needed needed. So our goal isn't going to be to eliminate anxiety. It's going to be figuring out how to coexist with it and recognizing that there's a pattern to some surges of anxiety, like around scans. So helping someone build a toolbox around that. Again, part of that toolbox is going to be an acceptance that it's there. And that kind of paradox, that part of a way to cope is to understand this is there. I get why this is there. So you don't get in a battle with it, is something that we can support patients with. There's such a tendency to not want to feel badly. Of course, that's everybody feels that way. This idea that we are driven to not feel badly. And so people get in a battle. But one of the things around anxiety in particular, but kind of all sorts of distress, is the more we try not to feel something that is absolutely normal, typical, and expected, the louder the volume on it gets. So we often use the metaphor of like, if you try not to think of a pink elephant, well, what are you thinking of? Pink elephant, right? So we bring these concepts in around, an acceptance that, of course, when you're getting scanned, your anxiety is going to surge. So don't fight it. We accept it, allow it, and we can also do things that help people redirect their attention, help them be more present focused, because anxiety is all about the future. So we bring in tools that help people come back to and return to the present. I try personally not to promote distraction as a concept, even though it's often what we're doing, and just reframing it as engaging in other things, because the connotation with distraction is that you can't handle the feelings. And what we're trying to promote in people is like, you can, like, their feelings. Right now, we're just talking about feelings. Feelings themselves are so uncomfortable, but they're not dangerous. So we try to build in people the capacity to be with whatever the distressing feelings are, including anxiety. And again, around scans, equipping people to come back to this moment right here, right now, to get through those 2 or 3 days until they get the news.
Yeah, I mean, I always tell our patients, focus on what you can control, right? I
Absolutely.
always feel like worrying about stuff that's out of your control, in my opinion, is just wasted energy. And when it comes to cancer patients, right? You've done the treatment, you've had the surgery, you're controlling what you can control. You can't control what this scan shows. So I feel like that's all wasted energy, and that's what I try to tell our patients. But what about medications? How often do you have to
Mm.
use anxiolytics or any other type of mood stabilizers when it comes to these cancer patients?
Yeah, I mean, that again, it really varies. I think when there's a marathon, on the one hand, when there's a marathon of distress that you're about to confront, we want to build capacity in someone to feel like they can handle it. So we want them to feel like they have coping skills and coping tools. At the same time, these are heavy lifts, these are heavy weights that we're asking people to psychologically carry. And if someone for that period around the scan feels like they would benefit from an anxiolytic, something to help manage their anxiety in the short term, then that could be something, having a consultation with someone a psychiatrist, someone who specializes in psycho-oncology, could be really useful, or sleeping aid and things like that. And then there are people who are more profoundly affected by the diagnosis, or their experience, or the stressors that come up around it. And so having other kinds of psychopharmacological agents, antidepressants, and some like that, that might be part of their treatment plan. And that makes so much sense. Again, we don't want people feeling like while they're confronting something so hard, there's something wrong with them to feel distress around it.
And you talk about being surrounded by family and support and how important that is. I've noticed that when my patients don't have good family support, a good friend network, it's a much worse prognosis and they just can't handle it. Tell us in your experience how important support network, family and friends is to the overall psychological well-being and overall prognosis, because I think the two are very tied into each other.
Well, I'll start with the psychological well-being. Having family and friends who have figured out what that person needs can be an amazing, amazing thing. I think the struggle is sometimes that that one's network doesn't quite know what to say. So if you're lucky enough to have people who get it, who when you're feeling, and when I say get it, meaning that they're not trying to, they're matching where you are. So one thing I think patients struggle with sometimes is when friends and family, let's say they're feeling really anxious because they concluded treatment, and their friends and family are like, "This is amazing, let's celebrate," and they're like, no, I felt much better hands when I was going through active treatment, when I was doing something about this. I don't feel like celebrating, right? So there's sometimes this mismatch, or people look okay, but inside or physically, they're having a lot of pain or discomfort or worry. And everyone's like, so this is great. You look great. And that's not matching. So sometimes that mismatch can leave patients feeling more, even though they might have a wide network of people who really care, it might make them feel more alone because they feel like their people don't get it. And so sometimes some of what we do is bring in family and friends and try to educate them about all of the complexities of being someone who is living with a cancer diagnosis. And sometimes we practice what to say to educate your people, to say like, well, actually, I don't actually feel like celebrating right now. I'm pretty worried that I'm now not going to be seeing my medical team as often. That freaks me out. And so, how to help the people around you get it is something that we can also do to support people. But to your point, absolutely, when you do have that positive support where people get it, they're meeting your needs, they're helpful, workplaces are accommodating, all of that is in place. It's a wonderful thing, and we hope that for people, and we try to cultivate it, like I said, by helping to educate those around the patient. You asked about the connection to prognosis, and I guess, do you mean the ultimate prognosis of kind
Correct,
of
like
how people do?
how they do with their cancer, overall survival, progression-free survival.
Yeah, that's a tough one, I feel like, to comment on, because we wouldn't want someone who doesn't have that community to feel like they're at higher risk in a way. So I would be cautious to say, if you don't have that, we're going to make that direct connection. I think instead what we can do is talk to the people who don't have that and build it, help those individuals build in supports. If it's not family and friends, there's so many organizations out there that support cancer patients. And maybe what we do is we connect them to communities of other patients who become their family. So that's something that we can do when we recognize that someone is more isolated, or even if they have a huge network, we understand that that network of people is not quite meeting their support needs.
And like you said, everyone goes through it differently, right? There is no
Mhm.
typical patient. In your experience, how do age, gender, ethnicity, and religion impact cancer psychology?
Yeah. So I think, again, it all has to do with someone's worldview. And let's take age, for example. If someone is younger, their point of view right now, it might be where they're not thinking about health concerns at all. And so, and it's not aligned with their goals, their plans. It completely derails the life course that they're on, their developmental stage. So for that individual, the shock, the added feeling like nobody gets it because their peers are totally not there, the observing other people who are going on with their lives when you're in a totally different space, all that comes up around that is that can be so hard. And so of course that's going to have an impact and be different than when you might be older and in your circle of friends and peers there are other people who have gone through maybe not that exact diagnosis but the cancer experience that you can lean on. So certainly the support, the kind of looking at your contemporaries and how that's how it makes you feel to be like the only person in your world coping with this is going to make a difference. And then I think culture, religion, things like that that are more socially informed also affects how people take on their diagnosis. There are messages about cancer diagnosis, what it means, how people developed cancer that might lead to feelings of stigma that might not be helpful and cause more distress. There are religions that are wonderfully supportive and give you a framework for making sense of any adversity that comes your way. So all of it is very influential, but how it's influencing really depends on the religion, the ethnicity, where someone comes in relation to their sociocultural background background, if it's something that they find is helps their framing of this and makes things make sense and gives support, or the contrary. But very influential. Just hard
Yeah, I
to
mean, like
count
you
all of
said,
them.
there's
Yeah.
definitely no cookbook
Yeah.
recipe because
Yeah.
everyone's different, everyone's background, like you said, religion, gender,
Yeah.
support network. And something else you mentioned earlier on that I want to delve into again, people who have a cancer history in their family, right?
Yeah.
What have you noticed a difference, cancer psychology, when a patient comes from a family, let's say they're a woman and breast cancer is rampant in their family. Well,
Yeah.
how do you find that cancer psychology to differ from people who are newly diagnosed, never thought they'd have cancer?
So again, I'll say it's influential, and then how it's influential is going to vary on what they've witnessed, right? So if someone witnessed a relative go through a horrific experience, and now they're diagnosed, their own anxiety about what lies ahead is going to be affected by that. So they might be really, really anxious. Whereas someone else who had someone who was touched by cancer, had a diagnosis, had a relatively manageable course of treatment, and is now thriving, that person's reaction could be totally different. So it absolutely is influential, but how it influences someone's going to vary based on what they've seen, they've witnessed, what they, if they've lost someone to the illness, that's going to impact things for sure.
Now, what about type of cancer? Are there particular types of cancer that you've noticed are more distressing than others? I know it's hard to differentiate because all cancer is going to be distressing, but
Yeah.
are there particular types that you've noticed are tougher to deal with?
Well, I think things like stigma do affect how someone takes things on. So, certain thoracic cancers, head and neck cancers, that might be where people are kind of thinking about how did that cancer develop, right? Where that's coming up for people, and they feel stigmatized. That's an added burden for individuals who are coping with the diagnosis, and also might feel that there are reactions from others about the diagnosis, wondering how did this happen. Um, there are some cancer types like pancreatic cancer where there's known associations with lower mood, with depression, because of cytokine reactions and things like that that affect people. I think there are rare cancers where there hasn't been as much research or attention or community, where that's another kind of issue that'll come up for patients, where there's anxiety because they don't think all hands are on deck finding the next treatment as they cope with, even if again in remission, they think about the future. So people can feel like that added anxiety around that, and again that also um, narrows down the community. So if you're trying to find people with like diagnosis, so you can, who get it, who get the course of treatment, who get the unique aspects of this kind of cancer, when you have a rare cancer, that's harder. That said, let's take breast cancer, for example, um, where there is maybe a large community, but there are kind of communities within that are louder, and pink is everywhere, and all that. And some individuals feel like they don't want to be lumped into that, and that kind of uh, momentum and movement is not, they don't identify that, and it puts them off. So people who come at, through the cancer experience and are saying, cancer was a gift or something like that, and our survivors, can also, for someone who carries the same diagnosis, feel really isolating because that's not resonating with them. That's not how they feel about this diagnosis.
Now, what about the placebo effect in the sense that the mind is incredibly powerful?
Mm-hmm.
And I always tell patients if you're not going to go into this with a positive attitude, there's no point in even treating it.
Mm-hmm.
H How important is a positive outlook and mental state for patients battling cancer?
So I think if we're talking about their own well-being, um, we want to be really careful about prescription of positivity, right? Because it's one of these things, like when you try to do anything, it's kind of similar to that pink elephant concept, right? When you try to be positive and you're like, I'm not being positive right now. What's wrong with me? And then you're scared and sad and kind of self-critical. Now you're not positive because you feel like something's wrong with you, that you're having reactions of anxiety, or lower mood, sadness, grief. So that the idea that we think we try to support is is really more back to what you said earlier, which is around agency. And what you can choose are perspectives, are behavioral responses. Like I choose to get out of bed each day. But when we try to choose positivity in that way, it can backfire. So I think instead, a lot of the ideas that we center around is on that idea of free will. You cannot choose what has happened here, but you can choose how you respond. So these kind of existential concepts, right, that are um, meaning center. They're around finding meaning in all of this. And one idea is when we are suffering, when we are struggling, we can choose how we respond. That might be a perspective of, I'm going to look at best possible outcomes. That might be someone's, and we would absolutely support that. But if we tell people, try to think of that only, that's where that kind of paradoxical effect of, wait, I'm not thinking that. What's wrong with me? I can't think of that. I'm thinking of the worst case scenario can kind of mess with people. So I think when we're working with people, talking about their ability to choose their response, to find agency, to focus on what they can control, which is a perspective, a place to kind of focus on these, or the moment, to focus on the moment, to come back to the present. That's what we can help support people in. And we want to be a little bit careful about prescribing positivity for those individuals where it's not coming naturally. So that's my thoughts on that kind of idea. Do we want it for individuals? We want them to kind of maintain a sense of hope and engage. Absolutely. But we want to be careful for that. Those individuals who are going to hear that have very natural reactions of sadness and anxiety and so on, and then say, what the heck's wrong with me? So that's what we want to guard against because
Yeah,
that's
it's a fine
normal. Their
line.
reactions make sense. Yeah,
It's
absolutely.
a very, very fine line. You wanna push positivity without making them feel guilty for not being positive at the same
Right, or
point.
think something's wrong with them or that they're actually threatening their health, right? So there's this other risk we call it the tyranny of positive thinking that I
Mhm,
think is very much part of how there has been a lot of popularizing of this idea, but for the individuals where it's that is just hard to, for lots of reasons, like they had a family history where it was a terrible outcome. So of course, I'm going to keep back coming back to that idea that someone's reaction always makes sense. And so it makes sense that someone is like, well, it's really hard for me to be positive when my relative had the same diagnosis and they died and the treatment course was really awful. So we're going to kind of have compassion for that reaction, acknowledge that it's hard to think in a different way, and then give them maybe other things that they can focus on choosing to attend to. Again, coming back to your idea of what can you control in these circumstances, and part of what people can control is how they're going to choose to respond to their predicament. Part of that person's predicament is that they have this in the background, that they have this other course that they know of that
mhm.
was not good. And so we're going to kind of support them in thinking about, okay, where do you have agency in this? Who do you want to be in this? Again, come a lot of existential work that we do around who do you want to be? How do you want to respond? What matters most? What are your values? That's where we can focus our lens a little bit more.
Now, something I mentioned at the beginning, I feel like cancer psychology is very much underappreciated. In your opinion, how do we raise awareness of
Hmm.
cancer psychology, and should all cancer patients be referred to a clinical psychologist like yourself?
It's a great question. We want to raise awareness. What you're doing right now raises awareness, right? So in the media, we want more of an continued acknowledgement of the importance of this in treatment. And in institutions, we want resources to help people recognize that it is normal to need support around this. Not all institutions have resources or the same level of resources for support, but certainly part of comprehensive care is attending to the psychosocial needs. And so if there are greater needs than a given setting can accommodate, we certainly can find people in the community more and more in terms of those of us who do this kind of work, psychosocial support. There are more and more trainings out there. And so for providers, clinicians, I would absolutely recommend getting training and in how to the nuances of care if you work with health populations at all. And so I think it really actually should be kind of part of regular training for clinicians so that they can also recognize when someone might need a little more support. Would it be amazing if in every cancer setting there was at least a consultation? That would be an amazing thing. But we recognize that resources are limited. And so we do things like screenings for distress and kind of recognizing when someone does need that added support beyond their informal community. Psychoeducation about everything we've been talking about, that's what we're doing right now, psychoeducation, is something that we can provide all patients though, so that their expectations are managed and they don't feel crazy for reacting to something that is by and large just hard.
Yeah, I mean, I would like to point out how Sylvester has comprehensive cancer care,
Absolutely.
hiring people like yourself to lead the clinical psychology division so that patients, should they need it, have a tremendous resource. I think that's huge in terms of overall cancer care. And then give us your crystal ball view. And this is the last question because I know you're super busy, but how do you predict cancer care and the psychology of cancer is going to evolve over the next 10, 15 years?
It's a great question. I think one of the things that's really important in all care is that it's evidence based, right? So we want to continue to study and evaluate the kinds of supports that actually are helpful and not harmful in the realm of psychosocial care. So my hope is that we develop a bigger cadre of evidence based supports, and that these are disseminated to all sorts of settings, particularly those that have fewer resources, where there are underserved populations, and that we are tailoring these evidence-based approaches for different groups and populations with different backgrounds, so that it really meets the need of that group. My hope is that over the next 10 to 15 years, this is part of training for clinicians, so that they are in training in evidence-based approaches with a kind of that cultural competence, where they know that different ideas might apply differently for different groups. And that becomes part of standard training. And that cancer treatment settings are equipped with the resources of these trained professionals. That would be the dream.
Wendy, what an amazing interview. I just want to backtrack and say that as a surgeon who does cancer surgeries, your role is absolutely vital. Seeing these patients, and everyone focuses on the physical, the treatment, the medications, the chemotherapy, the radiation, but the mental wellness of these patients is absolutely essential for their overall prognosis, getting them through treatment, staying positive, helping them handle all the anxiety and all the different
Mhm.
phases of grief that you went over earlier. And so I think that all comprehensive cancer centers like Sylvester should have people like yourself to help these patients out. And thanks for promoting it. Thanks for raising awareness. I think it's an absolute critical part of any holistic cancer care.
Absolutely. I couldn't agree more. Absolutely. And thank you for raising awareness. This is exactly the way we raise awareness, is that people who maybe otherwise weren't thinking about these kinds of ideas, or recognizing that there is that support out there, reaches out, asks their providers to help connect them to services. So thank you
I
for
mean,
that.
it definitely takes a team. It takes a team from everywhere, from the surgeon to the oncologist to the radiation doctors to the clinical psychologists, and that's how you get the best outcomes. So again, thanks for all you do, Wendy.
Thank you so much. It was great chatting.
Take
Take
care.
care.